everyone. I hope you enjoyed the dinner. Now, this is a session with a difference. Nightmare session was conceptualized as a session where youngsters would enjoy one, watching presentations by other youngsters, being judged by experienced mentors, and also it would be more informal where you could ask your questions about complications, clear your doubts, and make the conference even more interactive. And because it's 9 p.m. to 12 a.m., more like a horror movie, looking at complications like a horror movie, in spirit with the forthcoming Halloween. All right, so let us start this session. In the beginning, I would like to invite the chairpersons on the dais, Dr. Amit Sanghvi, Dr. Anil Dhal, Dr. Colm Hanratty, Dr. Florim Kukuli, and Dr. Shantanu Deshpande. So now I would like to invite the first presenter, Dr. Kunaal Makkar, uncommon cause of early stent thrombosis.
So he alluded to having a horror movie 9 to 12. Those who had romantic interludes earlier in their lives or careers also went to 9 to 12 movies for other reasons. So interventional cardiology is like a romance, right? So the hall will always generally be full whenever there are complications being discussed. So we hope to learn from you guys and maybe pick up a trick or two.
Thank you, Chris, organizing committee, for the opportunity. I'll be discussing an uncommon cause of early stent thrombosis. My patient, a 40-year-old male, presented to us with rest angina. His ECG was suggestive of inferior wall MI. We took up the patient for emergency cath, and it showed a RCA disease, and he underwent primary percutaneous coronary intervention to the RCA artery. He did well, discharged the next day on dual antiplatelet therapy. He again presented to us a week later with chest pain. ECG again showed changes in the inferior leads.
Would you care to specify the DAPT?
So it was prasugrel and ecosprin, 10 mg and 150 mg with Rosuva's high-dose. So the angiogram done at the initial setting shows that there was a significant ostial RCA disease marked by the absence of the backflush and dampening present, followed by proximal cutoff of the right coronary artery. The left system showed a borderline disease in the proximal LAD and proximal L6 artery. So we went to work and crossed the lesion with a Fielder FC wire, and we were able to achieve some antegrade flow. And we, after pre-dilatation with 2.5 and NC balloon, we did a drug-eluting stent were deployed from mid to ostial RCA. 2.75 into 24. Followed by 336 sirolimus eluting stents were deployed. And we were able to achieve some TIMI2 flow. Patient did well, his angina settled, ST resolved, so we are happy. And we observed him for a day and discharged him the next day. In the readmission, the patient, when was taken up for the emergency cath, showed this picture, which shows some haziness. It shows some haziness in the followed by decreased flow in the right coronary artery. By viewing the caudal view of the right coronary artery, we can see an outpouch that is seen in the proximal segment. In the fluoroscopy, we had a doubt that something had happened to the drug-eluting stent. So we had current challenge with us was that the angiogram had probably a thrombus in the proximal drug-eluting stent with a small microaneurysm. No intravascular imaging was available at our center at that time. The patient was in shock, the ongoing angina, so option for CABG was not present in our center. So our options left to save his life was a percutaneous coronary intervention, either a drug-eluting stent or covered stent, depending upon how the aneurysm behaves during the intervention. So we went to work. So the thing that we encountered at this point was we're not able to engage guiding catheter because of the previous ostial intervention. So we took the diagnostic JR catheter and wired it, and we wired it with the Fielder FC wire again. And using a small balloon, we took a stent boost. to see actually what was happening. And to our confirmation, there was a proximal stent disruption, type 4 stent disruption as per the Pompas classification. So our plan was to crush this disrupted stent segment and deploy another stent for this patient. So we first crushed it with 2, then 2.5 and 3 by 15 NC tricarbit balloon. And we only had the stent boost to confirm that we have achieved a good crushing of this segment. After we were satisfied, the plan was to deploy, and there was no increase in the size of the aneurysm and there was no perforation. So we're comfortable deploying a drug-eluting stent. This time we chose a Xience 3.5 into 18 stent and deployed, though there was significant overhanging from the aorta, but our aim was to actually cover the crust segment, so we left with this option. And to our bad luck, post the deployment, the wire came out and the guide disengaged. So we again had to re-engage, this time with the AL1 catheter. Though by this time his angina had settled, hemodynamics had improved, so we were reasonably calmer what was going on. There was a distal haziness in the stent that we had deployed. So we were left with two options: either there's a thrombus or with a geographical miss while deploying the stent. We again wired it and used a stent boost that was available to us, and we confirmed over here that there was geographical miss present at this point. But the patient was stable, angina had settled, so we're against deploying another stent to increase the metal burden. We just did a balloon dilatation for him and call it a day. And we took him up for a check angiogram after 6 weeks. The patient was doing one. He has been under follow-up for the past 1 year, and he's symptomatically fine. After 6 weeks, there was good antegrade flow reduction in the size of macroaneurysm. Learnings from this case will be complete transection of the stent can be a cause of early stent thrombosis, especially in RCA osteal intervention which has significant calcification. Stent boost can be used in the absence of intravascular imaging. Diagnostic catheter can be used for percutaneous coronary intervention, especially in previous osteal RCA intervention. Repeat stenting with drug-eluting stents can be used as a bailout therapy even in patients with previous cases of stent disruption, though they are associated with having a pseudoaneurysm. Significant osteal calcification and tortuosity are probably the risk factors that have led to stent disruption in this index case. Thank you.
Case, can you go back through some of your angiograms? Is it possible to go replay that?
PowerPoint again.
In particular, can we see what were the two stents you put in at the index procedure? Just go back to the start.
So it was 2.75 into 24 and 3 into 36 sirolimus eluting stent nostrum.
So what was the one on the ostium? Sorry, what stent did you put in? A 336.
336.
And it looked from your initial setup that it was positioned well into the aorta. Can you go back a couple of slides? The first clear stent that you did, yeah. So play the next one, or go forward. Go forward.
The previous one or the forward?
No, the first clear stent that you did.
This is the first stenting.
Yeah, no, the clear stent. The first stent boost.
Okay, the first stent. Okay.
Okay, so see here, you've got stent in the aorta with a disarticulation, and then you've got a geographical miss at about 10 o'clock. So what do you think is going on? So that was a 36 millimeter stent.
So this is evidently a stent fracture which has disrupted. Now, this could have been mechanically induced by guide catheter movement at the time of the index procedure. And if there is excessive movement, stents can also fracture without having mechanical disruptions being caused by guide catheters. So it's a little unusual to have this without a mechanical cause. So I would think, when you were doing the index procedure, did you have any issues with the guide catheter?
No, sir, it was
You had taken a Judkin?
Yeah, Judkin's diet catheter.
You had taken a Judkin, right? So you were not with an Amplatz type guide catheter. So, but I still think that this was mechanically induced because it's a little unlikely. This is not one of those areas of the heart which is prone to excess motion.
Yes, that's
But presumably, whenever that stent, if it did fracture and is separated, if you go back one picture, that stent with cardiac cycle, in terms of explaining the dissection, see the stent is going from 2 o'clock to 7 o'clock. So with each cardiac cycle, that is going into the vessel wall, and that's where you've got that
That's why you've
hydrogen.
got the microaneurysm. That's why, because there would obviously have been a kind of a mini perf which is causing the microaneurysm.
The question is, why does that stent disarticulate to such a degree in such a short period of time?
So I still think it is mechanical, but let's get
Yeah.
get some of the panelists.
So, this is the right coronary artery, and it's a very tortuous artery. And at hinge points, this can happen. But as you said, one thing is this might be an undersized stent for the ostium, might be 3.5 little malapose stent, and with your guide, it got little damage. That might be the reason. Second is a excessive movement at the hinge points. This is a very tortuous artery, I suppose. And this is a very thin stent. Thickness of this stent.
it's around 75 micrometers.
See, most of the current generation
Yeah, very
stents
thin.
are going to be 70 micron strut thickness and below. So, especially up to 36
So
millimeters.
see, and third point is nowadays these stents get elongated with the post dilatation. If you are starting distally and coming proximally, the stents can get elongated, and which might have come into the your aorta. The stent has come into the aorta more. And thirdly, treating these stents are like such a kind of a problem is going to be very difficult, frankly. You have gone through the struts, your wire has gone through the struts, and then you are dilating. I think you still managed it very well in the end, actually. It's because even engaging these right coronaries with such a
It
hanging
can be a
stent,
nightmare.
it's a
to
nightmare,
engage,
frankly speaking.
because you
Still-
have something mechanically which is occupying the ostium of the right coronary artery, and it can be a nightmare.
Well, you can see that the wire and the balloon are through the struts, and you've got about, 8-10 millimeters of stent in the aorta. But you don't really have much of a choice, and you're better to exclude it at this stage rather than trying to wire through the struts.
Whether there is another disruption in the proximal part, just below the bend, is there
Yeah,
any
you
other
can see
disruption?
at the point where there is a
Yeah.
overlap,
Yeah.
just at that point there could be another disruption, and that is probably one of the reasons why you also had
Thrombus.
an
Additional
issue,
thrombus.
a haziness, which was seen distally.
So, what then the
Yes.
point of discussion comes whether doing NC from distal to proximal or proximal to distal will make a difference and will prevent this in future? So the theory is that we used to do the NC from distal to the proximal part of the stent. But nowadays the theory comes that you should do.
I think this exercise is largely theoretical. The same thing applies even to stents. I know the current fashion is to put a proximal stent because we have guide catheter extensions and we are not so worried about going distally. In the days gone past, we used to deploy the distal stent because after having deployed a tortuous proximal stent, we were not confident of being able to deliver a distal stent. So things have changed. Yeah.
Yeah, what point you are making, I think there is a bench studies on that basically. If you put a stent if stent is like you are putting a 3 millimeter stent and proximal artery is 3.5 millimeters. If you dilate with the 3.5 millimeter stent gets elongated. But if you start proximally and go distally, the stent doesn't get elongated. That is shown in bench studies. So especially in osteal lesions, you have to be very careful. You start proximally and go distally.
Yeah, but this is, I think, some characteristic of the stent itself. Because for a stent to fracture at 2 points, it reflects, there could be some inherent disruption.
Is
So
there
current
calcium?
generation of thin strut stents.
Sir, is there calcium there just at the top of the dislodged stent? And probably during deployment of the original stent, the calcium sheared into this.
We don't have imaging, we don't have any ways of confirming it or denying it. Yeah, but that could also be contrast which is being imaged, because we know that there is a small microaneurysm there. Yeah. When you pull back the balloon, yeah, so that's what is mechanical. So We used to get LSDs. We've seen that happening with different stents, especially as we have become more thin strut stents. But we've seen elongations happening. We have seen longitudinal stent deformations happening.
Especially
Stent deformation.
Stent deformation is,
fractures
yeah.
is,
Fractures
very
don't
unusual.
happen like. I think probably in the stent is deployed too much in the ostium. There is calcium there, and that movement is probably lead to stent fracture. Because fractures we don't see even if you.
have the distal fracture.
I think
I don't know whether that's a fracture there or
Look at this point.
it's a geographical miss there
It's a
probably.
miss.
He's not overlapped it.
What is happening here?
Probably
Yeah,
it's a
I think-
geographical
well,
miss.
see, I
sir.
think
He's not.
Unlikely. You can see. It's unlikely to be a geographical miss when you are deploying such long stents. I would expect a little more overlap.
So maximum site of stent fracture is mid RCA because of its a hinge point and like whatever reports maximum which happens later on.
Yeah, any tortuous vessel where there is a lot of movement, mid-LAD, where it goes intramyocardial is a very important. I'm actually always petrified because what looks like a sitting duck, maximum perfs happen there because that intramyocardial cause. So that's always something to be careful.
final point from the audience before we move on.
I think conventional teaching matters most. Probably with the fear of using more dye, we tend to take the lesser suits after the completion of procedure. So taking caudal views or without wire to 2 or 3 views might have helped. And second thing, being a proximal RCA, we can easily think that it seems under. So using good NC or larger
I think
NC.
one of the morals of the story would be that we should have more imaging available in more places so that we could have ensured that this was optimally deployed 1:1. And if it was a grossly undersized stent, then there is a potential, as was said, that there is going to be severe malapposition and a potential for stent fracture.
Saying all-
Anyway, great presentation. A lot of food for thought. Give him a big hand, guys.